Welcome back to the Rural American Surgeon. This is the second of a two-part series with Dr. Amy Vertrees, who gave us so much gold in her first interview that I just had to keep it all. And we have to talk today about the inguinal hernia, do's, don'ts, how's, why's, and everything in between. Let's get into the show. Let's talk about exactly now. So say we've got somebody with a initial bilateral inguinal hernia, and we'll say it's a man to make it all easy. And you've made the decision now, all that's behind us, to come to the operating room for a open or a laparoscopic versus a robotic inguinal hernia repair. And what makes the difference? Who gets lap and who gets robotic for you in your practice?
Oh, that's a great question. So when you think laparoscopic, you're going to have TAPP or TAPPs, and TAPP is going to be mostly, laparoscopic. I don't know of, I've not really heard of people doing robotic TAPPs, but of course you can. So I typically do TAPPs now because I do the same as I do robotically, which is, through the abdominal cavity, you pull down the peritoneum and then you put the mesh in place. The biggest difference between a laparoscopic and robotic TAPP repair is the robotic arms bend on the inside. It's a lot easier to sew things. And the visualization is a little bit better. So when it comes to what I prefer, robot is what I would prefer because I find it simpler and easier. So I'll go through each of the principled steps of both operations and compare the two, because then you can kind of see the main differences. Because in one hospital, I have access to the robot and the other two I don't. So it really depends on where the person is of which one that I choose. That's typically my choice now.
So let me pause. So basically, if you have a robot, you're doing it robot. Otherwise, you're doing it lab.
Correct.
But it's not to the point where you make somebody drive to the robot.
No.
Okay. Very good. So which one do you want to start with?
So I'll start with actually both because I think they're both a similar approach. So both of them, the main principles of the operation are you want to give yourself as much room as possible. So the main challenge you can have is someone has a short torso that where you're going to put your ports. I like to put mine as high as possible because laparoscopically, you may be a little far away, but I haven't really found that as a problem. Robotically, you have the ability to extend the arms there too. So the further away you are, the more space you're going to give yourself. So I tend to start access at palmar's point in the left upper quadrant. So if I'm using the robot, I'll use the Verus needle and then put the port in. If I'm using laparoscopic, I'll do OptiView. So either way, I access in the left upper quadrant at palmar's point. So my other
when you come in optical laparoscopically, do you have any gas on the port as you go in?
Yeah, I do. Because, I can do them both pretty fast. So if I do OptiView, a lot of times I'll just OptiView, then put the gas on. So I guess... So
is the gas hooked up as you're coming in optically? Or is it you put the port in first and then put the gas after you feel like you're in the abdomen?
As I'm talking through it, it's like, no, not typically. Now, I will keep the gas on if I'm doing it for the gallbladder, but typically I just access OptiView without gas.
Okay. Got it. Thanks. Just a little nuanced
it's so
question.
Funny. As I'm teaching my junior residents things, it's so funny because they ask me how I do stuff. I was like, hold on, give me a second. I got to retrace my steps here because so many things become automatic. I don't even remember.
Right.
So I access left upper quadrant palmar's point. The other two ports are at least a hand's width apart. I do try to put the ports within the rectus muscle, try not to do it in the midline. So I'm decreasing the risk of having a hernia recurrence there too. So for typically, I'll have just the three ports, the camera in the middle, and then the next step is going to be taking down the peritoneum. So whether I do that with hot scissors laparoscopically or with scissors for the robot, it's the same case. So you want to also make sure that you're not shorting yourself on the flap because it's so much easier to pull a flap down than it is to pull the flap above. And you want to have enough flap that you're going to be able to cover the mesh. The biggest challenge with that is that the peritoneal layer is going to be very thin. So the more you tear it, the more you got to repair it. So it's a little bit easier to repair holes robotically. It's a little bit harder laparoscopically because you're either using a suture, which is a little bit easier with the V-locks, but it's still a straight stick, two-dimensional screen, so it's kind of a pain. Usually in the end, when you're closing the peritoneal flap, you're going to be using a tacker laparoscopically, and that can cause pain with sharp shooting pains if it irritates the muscle. And also, you have run the risk of gaps in the peritoneum. So the nice thing about the robot is that you can sew completely the opening very quickly compared to if you were trying to sew it laparoscopically. And also, you run the risk of just adding more expense to each of the case too. So the idea that you don't want to necessarily use all the laparoscopic equipment that you have or all the robotic equipment you have. Keeping it simple and easy is also going to keep it more affordable. There's that phrase that you do it safely, you do it well, and you do it cheap or something like that.
Yeah, in that order, sure.
Exactly.
Yeah. Sure. So what mesh do you use?
So I've used a couple different ones. Right now I'm using the Pro Grip, because they say you don't have to tack it. That's a lie. I always tack them. So because the biggest problem laparoscopically, you're going to have a recurrence if it rides up. So the ProTack the Pro Grip was sold as you don't have to tack it because it's going to secure to the tissue. And what I have found is it still rides up if you're not careful. I always secure to Cooper's ligament. And laparoscopically, I'll do that with a secure strap. And robotically, I'll sew it with a Vicryl. It's like a 2-row Vicryl.
So still absorbable with the thing that you secure, and you think that the scarring around that area most likely is strong enough to hold it medial where it's supposed to be, so there's no recurrence, right?
Correct.
Okay. Very good. And so you're using ProGrip both laparoscopically and robotically.
Yes, and I've used the Bard 3D Max mesh. I actually like that. I think the Bard 3D Max is a little bit more inexpensive than the ProGrip, but it's just what we have at the hospital. You sort of get used to it. So one hospital has
probably
Bard,
depends on your contract too, but yeah.
Yeah, exactly. One hospital has a Bard 3D Max. The other one has the Pro Grip, and I'm comfortable with both.
Yep. Got it. So you've got the peritoneum peeled down either way. We talked about the port placement. I want to go back just 1 second. Palmer's point, your access point, that is, what are you using there? Is a camera going there, or is that actually your left hand?
It'll be my left hand.
Okay. So that's pretty high. And you don't have a problem reaching all the way over to do a right inguinal laparoscopically if you start at Palmer's point. What about a person that's a longer, do you do different if they have a longer torso?
I haven't really found that much difficulty reaching. And laparoscopically, so actually, as I'm thinking about this, laparoscopically, I don't always have the camera in the middle, which is what we usually do. Sometimes I'll put the camera to the further side so my arm isn't reaching over. Either one works.
Got it. And then where do you bring your mesh in, and what are the sizes of your ports in both cases?
I typically start with 3/5s, and I don't technically have to upsize one of them. What I'll do is I will take one of the trocars and go through the other one. So enter the far right and then go through the far left. I will pull the port out and I'll pull the mesh through the area, not through the port.
Okay. Just take the port out and pull it straight through. Yeah. Yeah, I can't get it to go through a 5. And so then you're getting by getting rid of the 5. I use a Hassan and then bring the port in through there. Or bring the mesh in through that port, obviously. Then you got to close that defect, and you have potential risk hernia there and whatnot, but quite low.
I do place Ioban on there. Don't necessarily always have to, the inguinal, but out of habit, I always did that for the laparoscopic ventrals. And because I do think, and it's a fair argument, that you are pulling mesh with skin nearby. If you do the port, it's kind of like a wound protector, but I've not had a problem.
Yeah. Okay. And then are they 8mm ports on the
8 millimeters in the robot, which is why I tend to avoid the midline.
Does it go through an 8mm port, your ProGrip?
The ProGrip will.
And is ProGrip sized medium and large, or how are the sizes?
They usually do a 15 by 30. And I will either, if it's a big hernia, I'll keep it at 15. And a lot of times I'll cut it down to 12 or 13. And I always round the corners, because getting the mesh to lay flat, those corners really don't add much to the repair, but they do kind of sometimes curl up, and I never want that to be a lead point. So I always add a little curvature to all corners.
Okay. And what landmarks do you use then after you get your ports placed and you're using your scissor to take down the peritoneal flap? Where do you start? And do you score it with cautery and then follow the lines dot to dot for yourself, or any special tricks like that?
Yeah, it's a great question. So I always try to start further back, because if I get a small hole in the peritoneum, then I'm still going to cover the mesh. Mm-hmm. So especially laparoscopically. So I usually just take the scissors and just go straight across. I don't score it. I'll pull it out just a little bit. And as soon as you open it, the pneumoperitoneum will open up that space somewhat. So you'll see it starts to develop that plane. So I pull it up gently because it does tear easily. And I mostly will do it sharp. Or robot is a little bit easier to kind of lay on the cautery because you could see the layers so much, but it's usually this loose areolar tissue that really shouldn't have a lot of vessels within there. So if you're in that plane where there's loose areolar tissue, it's mostly just cutting the peritoneum, then gently pulling it back, and then following that loose areolar tissue. So then it could be a little bit challenging to figure out where to start. So the landmarks, I'm always aware of where the midline is, the symphysis pubis, and also where the anterior superior iliac spine is. And so we can externally put some pressure on there to see where they are. So I typically will start in the safe place. So I always told the residents that there are safe moves and there's safe places. The safe places are in the midline and lateral. Safe moves are when you go in the middle, near the inferior epigastric. So I will usually just follow wherever the loose areolar plane takes me. And when I get to something that is confusing, then I will start and find, the symphysis pubis on that side. And then I'll find the lateral side. And then I know in the middle, there's going to be the rest of the stuff. And especially if you have a big direct hernia that is incarcerated, and then you're hard to figure out what things are, think of the things that don't vary. Symphysis pubis doesn't vary. The inferior epigastric you can find, and the anterior superior iliac spine, you can have external pressure to find that. So once I find those things, then typically what I'll do is I will follow the inferior epigastric down to where you see the spermatic cord structures. They kind of take a curve. So what I do in that move, especially, let's say a direct, this is where it gets confusing if there's a direct. So I'll start with direct first. If I find the inferior epigastric, the stuff medial to that, if it's on the right, is going to be direct. So then I know this is probably, if I don't see any organs nearby, this is probably just a plug of fat or something like that. So you can be a little bit more aggressive in pulling that out, as long as you know you're medial to the inferior epigastric.
How does the medial umbilical ligament factor in as a landmark? Because I find it's often hanging down. This would be the obliterated umbilical vein, correct?
So I take my left hand and lift it up. I take my right hand tip to tip, and I move it directly to the right. And what that does is it separates the things posterior to it. Because there was a time when we were kind of wrapping the cord, and I did that for a period of time when that was sort of, like a technique people were using. I don't do that anymore. But it was useful to be able to dissect circumferentially around the spermatic cord structures. So that technique of lifting it up and then spreading it to the right, separate out from the tissue behind it so it wasn't so confusing. So then what I did was I took my left hand, I pulled it back just a little bit, let the cord structures drop, and then lifted it up. And then I did tip to tip, and I traveled parallel to the spermatic cord structures. And a lot of time that would then snag the hernia sac. And then at that point, I'll see where the hernia sac is. Because as soon as I can identify where the hernia sac is, then I don't really worry about the spermatic cord. I grab the hernia sac, and I basically take everything off of the hernia sac from the cord. The main thing is, whenever possible, I try to grab on the adhesive side of the hernia sac. So now when I take these little small bites, it's 1,000 little small bites rather than big tears. So if I'm just pull, that actually goes much faster than if I try to grab a big bite and tear it.
Great. So then as you continue to peel it down, how do you know that you're low enough on your fold that you're ready to bring your mesh in? That groove.
It's a great point. And whatever it is, whenever you think you're done, do a little bit more. Because I have put the mesh in prematurely enough times and tried to dissect it with that mesh in there enough times to be so painful that I dissected a lot more. So usually now I can I could pretty much eyeball it, which is not really helpful for someone who hasn't done it for a while. But I can say, really what you want to do is you want to be able to grab the hernia sac and then hand it off to yourself so far in advance that it's going to cover, when that mesh goes in there, it's going to cover the femoral space, the direct and the indirect space. And when you lift up that peritoneum, it's not going to curve the edges of the mesh, because that's really where recurrence has happened, is the bend of the mesh at the back. So the more you could have your mesh lay flat, not near any kind of lead points that it could lift. And keep in mind that that abdominal wall is going to move somewhat, that you want to make sure that the sac is way back, so that if you pull that sac, it's not going to be messing with your mesh at all.
How often do you see the iliacs? Actually see them in your dissection? You try not to do that, or does it really bother you? Like when you're coming down on the deep inferior epigastric, you're eventually going to get to it.
That's a great point. Almost every single case, actually, because the finding Coopers can be a little bit of a challenge. I found that the symphysis pubis and the cord structures, it's almost always like directly in between there is the Cooper's ligament. So obviously it's going to be medial to the inferior epigastric vessels. So that's one thing that you're going to see. But I usually do like the midline and the core structures. Cooper is going to be directly in the middle of that too. So I always clear off Coopers. There, by the way, is almost always at least an annoying vein, if not the corona mortis, which is obviously can be life-threatening. So I think it's really important that you see Coopers to be able to confidently secure it, because it really is right next to the iliac vein. And so you want to be very careful that you know exactly where things are. And so I always clear off where Coopers is, because I intend to adhere to it.
Great. So if we can take 1 second on the corona mortis. So if you get bleeding when you're dissecting on the pubic tubercle, aka Cooper's ligament, what are your first steps? And then what if that doesn't work, your next steps?
Yeah, it's a great question. Usually the way that I dissect it, I'm pulling it away from it. So there's the where you get in trouble is that if you don't clear it off from when the hernia sac is pulling off, if you're not careful as you're pulling off the peritoneum, then first, if you pull it carefully back, then usually what you're left with potentially is like a little fat blob where the Cooper's ligament is. And so if you indiscriminately grab that and tear it, if you tear any fat in that area, it's going to bleed. So the first thing is to gently grasp something and give it a little bit of tension and cut things that you can see rather than pull fat, especially in that area, because there's almost always going to be that annoying vein that's going to be exactly where you want to put a tacker. And most of the time, it's not going to be an artery. It's going to be
you cut it with cautery?
I will typically do with cautery. So when it was laparoscopic, a lot of times I would have just like the hot scissors, things like that. And so typically I would, burn in that area. So now with the robot, it's a lot easier to see. And also if you're questioning it all, you can suture it, over sew it. But that's much easier robotically than it is laparoscopically.
Yeah. So say you're laparoscopically and then you got into bleeding there and then you try to treat it with cautery and then it's still bleeding. And maybe it's like pulsatile bleeding, but it's like kind of retracted.
Yeah, but usually they don't have like a 5mm clip applier. So I haven't really gotten into that, but this, I can imagine what I would do. The biggest thing is that I don't want to buzz anything that I can't see. So you don't want to burn anything. If you only partially see a vessel, I really should see whether that's an artery or vein or not. And so I don't usually use cautery unless I can kind of see what that is. And in the short term, you can just take a grasper, hold it for a second. And especially if you're encountering a lot of bleeding, the very first thing is just to put pressure on there, take a deep breath and ask yourself, what do I need next? So having hot scissors on there is probably going to be true for any of the cases that you have. Then your other available things are going to be, some more cautery type instrument, like a ligature or something like that. I don't think you necessarily need that, but asking yourself, is that what I need? A 5mm clip applier should be readily available in these cases because it's always on my, possible thing, because that's how I close the peritoneal openings when I have it laparoscopically. And so I think typically it would be first pressure, then expose it, then electrocautery if it's small, then 5 millimeter clip applier if it's bigger, then suture repair if you really have a hard time. But you definitely want to make sure that nothing is actively bleeding, because what will happen is it can go into that hernia space and it'll present as a very large scrotal hematoma.
Yep. And you talk about holding pressure and kind of pinching it, but I'd like to ask, do you ever bring a Ray-Tech in and hold pressure that way?
You can. Typically, you're going to need at least a 10 port for a Ray-Tech. So you'd have to have an upsized port. And I think this is where a lot of people get into trouble, is if they have not asked to have all these things available. So, whenever you're doing a case like that, most of the time it's going to be a straightforward laparoscopic inguinal hernia repair, things like that. But you always want to plan for what if. So on my what if things are going to have things like an upsized port and the 5 millimeter clip applier and an endoloop if I'm having trouble closing the peritoneum, which is the 5 millimeter clips alone. Those are, and then Ray-Techs are always available. But again, you'd have to have a port side. So what flusters people is not that they can't manage it, is that it feels like the decision fatigue and the overwhelm as they realize, I got to ask for this and it's taking a long time and I'm looking at this meeting. You can prevent a lot of that ahead of time.
Mm-hmm. Yeah, very much agree. But the Ray-Tech is probably one of my bigger things, but that's because I have the 10 in there. Yeah. So then I just drop the Ray-Tech and always can just be calm and catch your breath if you have any bleeding or whatever. So that's great. So you said you see the iliacs almost every time because that's kind of part of how you know that you get low enough.
To Cooper's, yeah.
To summarize that. Very good. And then you're going to bring your mesh in and secure it medially to Cooper's ligament. You talked about how you were going to do that. And is there some other step in between there?
Yes, before I put the mesh in place. And I did this mostly because I taught residents for most of my early career. And we had the Bar 3D Max mesh. They have a nice curve. But even with the ProGrip, it helped me teach residents, but I think it also helps orient. I draw a line where the iliopubic tract is, and I draw a line where the inferior epigastric is going to be. I draw a circle where I expect a direct, a circle where I expect the indirect, a circle where I expect the femoral. So when I stick the mesh in there, it's like, I just want to make sure the holes line up where they are. That keeps it oriented, because I think the biggest challenge when you're doing inguinal, you're at a bit of an angle. And so if you're at a bit of an angle, you can potentially get the horizon off. But if you draw the line and you look at the anatomy that doesn't vary, and you draw the circles where things are supposed to be, that's going to keep your mesh aligned, and it's not going to be drifting too far south or too far north.
Perfect. So now you've got it labeled, and robotically that you just roll up and put it through the port, right?
Correct.
You bring your mesh in, but laparoscopically though, you're bringing it in through, take your port out, right?
Mm-hmm.
Yeah. Okay. So then you bring it in, and then you secure it. The starting point is getting it all oriented, and then securing it medially, either with the secure strap or with a vicryl. Is that a 2.0 vicryl or?
Yeah, typically I'll do like a 2.0. 3.0 is fine too. So robotically, I'd have like a 2.0 vicryl for Cooper's, and also to close any of the defects if I had one in the peritoneum. And then I'll close the peritoneum with a V-lock, just because you don't have to mess with the tying the ends. So you can actually do that laparoscopically with that suture. And it has been a little bit more helpful, but honestly, like those, we just put the tacker on there. So I tack the mesh at Cooper's, and then medial and lateral to the epigastric, but making sure that the mesh lays flat. Because another thing, a mistake that you can make is attaching it and the mesh is not exactly flat. So I make sure that the mesh is flush with it, the abdominal wall, exactly where I want it to be, tack it at Cooper's, check that it's flat again and not twisted off the horizon, and on either side of the epigastric. And that secures it in 3 places, and that keeps that mesh where I want it to go. Mm-hmm. Then I pull the peritoneal flap up and then tack that in place. And that can be difficult if you have a thin peritoneum or multiple tears. Then if there's multiple tears laparoscopically, then what you want to do, or bigger one, I lift up the corner of the hole, I use a 5 millimeter clip applier to close it. And if it feels like it's under tension at all, I'll end an endo loop on there just to make sure that that hole in the peritoneum doesn't happen. I have seen, it wasn't in mine, but I saw it at M&M where someone had a small bowel obstruction through one of these small defects. So I do try to close all of them.
Very good. And then trying to keep those tacks out of the old triangle of doom and triangle of pain.
Correct. Yeah, don't touch that stuff at all.
Triangle of doom for the learning listener being the space where you see this triangle going towards the internal ring, which is your vas deferens or round ligament medially, and then your gonadal vessels laterally. Just don't go down below there. And then laterally, where you have your spermatic vessels, and then up to the iliopubic tract is your triangle of pain. So don't take them down too close to the cord, and just stay up above the internal ring, and you're generally going to be in the safer zone. What else do you have to add to that? That was an awesome overview of laparoscopic and robotic repair.
Oh, thank you. Yeah, I really enjoy those. I will say, like, the difficult challenges could be like if you have a large hernia sac. So a couple things that I would keep in mind. If you remember what the principles are that you have to do, you need to pull the peritoneum back and put the mesh on there. So I would not kill yourself finding a huge hernia sac. I would do the best that you can to resect the whole or to pull the whole thing back. If you pull the whole thing back, then there's not a hernia sac that could hold fluid within a large inguinal space. So first is I try to get the sac out. If I believe that I've pulled out enough hernia sac that I can adequately cover the mesh and I could lift the sac away from spermatic cord structures, I actually don't really have a problem cutting that sac and repairing it, as long as I'm going to have enough coverage of mesh. The downside of that, you're essentially going to leave a end of the sac that can accumulate fluid. But even if you don't do that, the person is at risk of having fluid in that space. And early in my career, I chased down many of a palpable mass in the inguinal canal area that was really just where the hernia was. So now what really helps post-operatively is explain this pre-operatively. So if someone comes to me with a large hernia, I'm going to say, okay, this is what's going to happen. I'm going to pull everything away from that space. I'm going to put hernia mesh in there too. The fluid is going to go both sides because it's mesh. It's going to start sealing off. Fluid is going to be in that space. You're going to feel like you have a hernia. You feel like you have a hernia back that is fluid. Give me a few months. So I found it takes at least 3 months for that to get better. So if they come into the office and they have this feels like my hernia, I hold my hand there and say, all right, cough for me. If it doesn't move with Valsalva, I do not do anything. Come back in 3 months. So I would not jump to the conclusion it's immediate recurrence, but you do want to have that as a possibility in your mind. But almost always it's going to be fluid, especially it's going to fill that space that you had. So I tell people to expect it. Especially men too, I'll have them wear a jock strap and say, look, we need to keep that space closed as best we can so fluid doesn't develop. I tell them to roll up a hand towel and use gravity to keep fluid from building up in that hernia sac space. And those are the things that I do, is both warn them ahead of time and afterwards, and definitely warn people that they're going to have black and blue and nothing's going wrong. It's going to be very impressive, and you can call me if you want, but I'm going to tell you it's fine.
Right, exactly. So even for a very large inguinoscrotal that's as big as the patient's head, that does not scare you, and you go laparoscopic.
Yes. And with a couple things, like especially laparoscopic, I would probably just put more tacks around the opening, obviously still avoiding the triangle of pain. But in that particular case, laparoscopically, I was securing them in different spaces. Now, robotically, you can potentially narrow that space a little bit more. But then typically what I do is I just sew the mesh around it, because really what you need is that mesh to kind of hold that wall in place. The biggest challenges with recurrences are typically the mesh rides up and it goes underneath there too. So even recurrences, a lot of times you can go back minimally invasive because it's almost always going to be underneath the mesh. So then making sure you have it adequately down. The bigger meshes can be a problem if you don't have adequate coverage superiorly. So you want to make sure that you have adequate coverage superiorly, and also I secure it in place to give us a fighting shot. But that's where like the Bard 3D Max, the extra large, is going to be helpful, or I'll keep the Pro Grip at 15 centimeters.
Yeah. So you actually close the hernia sometimes robotically, but never laparoscopically.
Yeah, for one thing, it'd be really hard, and a lot of times robotically, it's hard to necessarily close that space and expect it to stay. So right. I think it's
you're not doing a real, like you're not doing a McVeigh or a Bassini. Like you're not taking two structures like the inguinal ligament and stitching it to Cooper's or stitching it, to. So you're not grasping basically the conjoint tendon and bringing it down to one of those two structures, inguinal ligament or Cooper's ligament.
I am not.
I mean, not just you. I'm saying anybody that was doing it laparoscopically. So then it's not really, you're just kind of tucking it together. But but in my mind, it would make sense to do that, to keep it that way so that it scars that way. It's not that you're counting on that, but it, and that's the same reason, like when I have a large direct defect and I'm doing open, a lot of times I'll do a Bassini and then stitch the mesh over the top because you're just getting it out of the way.
Exactly.
Okay. That sounds good. And then what about the pneumoscrotum? You just squeeze at the end of the case, the scrotum and get the air usually out, or?
They can be really remarkable. The one thing that you can do to decrease this to some degree is you don't necessarily have to have it at 15 millimeters mercury, for your pneumoperitoneum. So I think that anywhere from 8 to 10 is actually okay, especially once you get started. But afterwards, this should be CO2. It should absorb quickly. And so usually we just try to, compress the gas so they doesn't like surprise them when they wake up.
Yeah.
And also just the jock strap, because that gas is going to be replaced with fluid. And that's really the problem.
Right. And so when do you image? I mean, obviously, if you think there's a recurrent hernia, you would do it right away, but you wait 3 months, something's still there. Do you image there if something's still there? And then other questions, when do you aspirate? When do you IND?
I don't aspirate fluid at all. If it's infected, that's definitely a different problem, because then you would have to worry about the mesh. I haven't experienced that yet. Typically, what I'll do is on my post-op visit, I will usually have an idea how big the hernia was before. If my fluid sac kind of approximates that and it doesn't move with the Valsalva, it's going to be a seroma. So then I'll bring them back in 3 months to see how things are. And if it's documented as smaller, then I was like, just stay the course. Is it bothering you? No, stay the course. And if I do any imaging, I have an ultrasound in my office. So I trust my ultrasound imaging more so than sending them off, because usually when I send off for ultrasound of the groin, they say, lymph nodes look all fine. And I'm like, that's not what I was going for. But I've got an ultrasound in my office, so I can identify it in real time, have them Valsalva themselves, things like that. I find that much more helpful than an ultrasound someone else does. And CT scan I don't find hugely helpful unless you have a big recurrence, and that's usually probably something you're going to be able to see. Yeah.
What kind of ultrasound do you have?
It is a Terrason, something or other. I got it back in 2020.
Yeah, that's actually coming from military. That originated with a military unit, and then now it's become the Terrason.
Yeah. It was
I have one too.
More inexpensive, but still good quality. And
you bought it new?
Basically an extension of the physical exam. Very helpful.
Did you buy it new?
I did.
Yeah. And so of a car. Do you, yeah, right. I think that's what was mine's like 25 grand or something like that.
I think it was like 25.
Yeah. So basically, do you bill for that? Do you put a report or capture images or anything?
Yeah. So to bill for an ultrasound that you use, you need to take pictures. And you have to have the ability to submit them if they ask. So, I could, but I often don't. It's, to get and that's mostly making a executive decision that's not worth my time to do it. Because the most I'm going to get is like $20 or less. It's going to take me an hour to figure out how to do it. So.
Yeah. And do you let it like raise the level of your E&M by 1 or something like that? If you're using intraoperative ultrasound, does it factor in like that?
No, usually I'm using it in the post-op period and to be in the global anyway. So you really couldn't charge for that anyway. I do it as an extension of physical exam. And then in that case, I usually just do that as, an extension of the E&M.
So I've recently had some discussions with my best friend ChatGPT and some coders about just because you brought this up, post-op coding. And I have been, is a seroma a complication of inguinal hernia?
It doesn't matter.
And
the only thing you get paid for is if there is operative intervention, I think. I could be wrong, but that's
what I have always done, but I'm being told that it's not true. So basically you get paid for managing a complication, and the 90-day global is only for routine post-operative, normal post-operative course. So if the bottom of your note says anything other than routine post-operative course, there should be a modifier 24 and an E&M code.
And I think it makes it more complicated because some of the hernia codes don't have globals anymore.
Right.
So, and I can't remember, I think the ventrals don't have globals anymore.
Correct.
The inguinals do. It's complicated.
That is correct. Yeah. So anterior abdominal wall, is a new block based on size and based on if it's initial or recurrent and incarcerated or not. And if that's the only one you did, then they dropped all of our values. And in order to tell us that was okay, which it wasn't, and nobody asked me, but they gave us our post-op appointment. Now, patients, you have to explain that to them because they're expecting now that to be part of your included global. You just have to explain, no, in their infinite wisdom, the whatever you call it, I can't come up with it right now, the task force, that decided this, they said, we are decreasing the value, the price of the inguinal hernia, and we're giving you that back. So that is now part of it. You just have to explain it. The question is, what do you do if it's a routine recovery and you did a umbilical hernia repair and a bilateral inguinal hernia repair? And I've always put that in a global. But I'm now being told that you should tie your note to the umbilical hernia and put a modifier 24. And that should be a billable visit. So okay. You talk to your own coders. I mean, it's kind of like talk to your accountant, talk to your attorney thing. I'm not a coder, but that's how I'm doing it.
Well, it's what you can code for and what will get paid. Yep. It's sometimes a big difference.
Yeah, but if you put like the inguinal hernia ICD-10 and you tie it, then it's going to kick out. But if you don't put your ICD-10 for your inguinal hernia, and you just put your ventral hernia code in, for example, or if your code is, seroma or hematoma, then you get paid for managing complications, basically is the message.
Very cool.
Guess. So anyway, that is a lot of great information. I think we should move on to the next segment of our show, which is actually the financial corner. I was wondering if you had a money tip for our listener.
The biggest tip that I have is know
Get
what your
coaching.
math problem. What's that?
Get coaching.
Yeah, no, actually, it's simpler than that. I just had a webinar called Math, Not Drama. So the most important thing that has to do with money is know what your money story is. And a vast majority have no idea how much things are getting reimbursed. And it's by design. If you're employed, it means someone in the hospital is determining that. And if you have private practice that is based on whatever your insurance contracts are, there is a way to figure out how much you're getting paid. The problem is most people don't know what that is. So my financial tip is to be interested in these things and not overwhelmed by it. And I would, especially, so if you're employed, then I would meet with your biller and coder and say, tell me more, just exactly like you described. Be curious about that. So first, know what the revenue cycle is. You basically see a patient. That is you generate an invoice, which is your note. Your invoice has on it what you did, your ICD-10, the diagnosis that you're treating, the ICD-10, and then whatever you did. Procedure is going to be CPT, your visit is going to be E&M. And that's basically your invoice for what you work. If you don't do your note, you don't get paid. So that is on you to not submit your invoice. And your invoice needs to be factually correct. And it needs to make sense. You cannot bill for a service that does not solve a problem that you're asking for. So you have to make sure that your invoice is correct. So then you submit it and someone's checking your invoice, coders. And then the biller's is sending it to the company. And then there's collections. And you are paid by the weakest link. So that is the most helpful.
Which could be you.
which could be you. And oftentimes it's us, because if we do not document on time, if we do not document properly, if our invoice is not in order, then it is typically we are the weakest link. Then it's going to be, is it coded correctly? Is it submitted correctly? And then is it actually collected upon? My kid had an ER visit and we didn't get a bill until 11 months later. So, and oftentimes if you're not aware, it's like my invoice is perfect, but they kick it back for some reason, like we want the path report, even though you sent it 3 times, then what'll happen is you won't get paid because they'll say we don't have enough information. So you have to be aware you will be paid by the weakest link of the revenue cycle.
Mm-hmm. Be interested. That's beautiful. What gets measured gets managed.
Exactly.
I love it. All right, let's move on to the next segment of the show, which is classic rural surgery stories. You have a story, a crazy story that we just wouldn't believe?
Oh, yeah. So I debated which one to do, but this one was interesting. The biggest challenge for this particular patient, this was a non-compliant patient who was not obese, who was a smoker, who thought they were obese and tried everywhere in the United States to get a gastric bypass, which of course no one would do. So they went to a resort in Mexico and got a gastric bypass. And they continued to smoke. And then something happened, but was also not compliant and didn't like doctors, the usual kind of thing. I can describe as a hissing cat. And so basically comes to the hospital just wasting away, like skeletal. And try to figure out what was going on. The anatomy was difficult enough. And everyone's like, oh, no, send it to a bariatric surgeon. Well, good luck when the person doesn't have insurance. That once they're admitted to a hospital, we tried to manage it and then said, oh, this is a little bit more complicated. So interestingly enough, because they were still a smoker, they anastomosis had eroded into the colon. So basically it went from the gastric pouch directly into the transverse colon. So the person had been malnourished for probably like 6-7 months easily when this probably happened. And anytime they ate, would have like loose stools. So initially saw the gastroenterologist who's like, I stick my scope in there and I see 3 holes.
Ooh.
So we tried to send it somewhere else, bariatric surgeon, things like that, and could not get anyone to accept the patient. And so they called me because at some point that delicate, combination of fistula that had happened fell apart. And the person is Thanksgiving weekend too, a couple of years ago. And I was like, well, I guess we'll have to figure out something. Anyway, in that time, I found that where that fistula was, the gastric remnant to the transverse colon had fallen apart. And I was like, well, I could fix this, but really what this person needs is a reversal of their gastric bypass. So in that moment, she was stable enough where I said, that her best option is to get as much nutrition as possible. And so we just ended up reversing her gastric bypass. She was never obese in the first place.
Mm-hmm. So she basically leaked. You're saying that when you say fell apart, she developed an acute leak, right? From that area? Which you would think that'd most likely be a perforated marginal ulcer. Right?
Could be.
Because, once you get an established fistula, it's probably not just going to explode, except for the fact that you've got that gastric juices
the marginal
there.
Ulcer eroded to the colon. The colon was acting as a patch. Did not was not there, I think, that particular long. Had just been sort of manipulated endoscopically, and I think really just kind of eroded that not strong connection.
What a crazy situation. Would you ever take a patient like that? They're sitting there. It's a catastrophe. You cannot get them somewhere. Like, it's easy once it becomes an emergency. Mm-hmm. But would you ever take them electively for something?
So it's a good question. In this particular case, I think electively we had different options. Could stick a tube in the gastric remnant and things like that. The main problem we have is a financial one. This person did not have insurance. I was trying to figure out a way to fix her as best as I could with as much as I can at the time. Electively wise, we would probably have gotten her to a bariatric surgeon to see whether, fixing marginal ulcer, caraphate, things like that. And, but in this particular case, it wasn't feasible. And I also knew that not to be, how do I delicately say this?
I can't
was
wait.
not a provider, preferred person.
Yeah.
Basically fired people left and right.
Yeah. What
Somehow
a
like
disaster. Yeah, I don't know. So how exactly did you reverse the gastric bypass? And did you know how to do it and you just did it, or did you talk to somebody?
Well, I knew that I was going to have to repair the hole.
Mm-hmm.
So it's all just anatomy. It was actually not as hard as I was afraid it was going to be. So luckily, because she was somewhat non-compliant, her gastric pouch was actually fairly large. So that's where the staple line was. It was likely a marginal ulcer. So what I did was I took down the staple line and I hand sewed the stomach to itself. And so once we had that, then I had a hole in the colon. So I just resected that and connected it back together. And then, repaired.
How'd you do that anastomosis?
So that one I did stapled.
Mm-hmm. And when you say stapled, did you do a anti-peristaltic, or how did you does the transverse colon come up?
End to end. Yeah. So side to side functional end to end.
Okay. When you say that, I know you're saying that, but are you bringing the two ends so it goes up to the end and then comes back?
Yeah. Yes. So I think I would say it would be anti-peristaltic.
Okay.
Now that being said,
because you could lay them side by side.
You can lay them side by side, especially. So there's a really nice video from Mark Solomon that talks about robotically, where you take like 2 centimeters from the end, so you add them, lay them next to each other, and you start I think it's like 6 centimeters or something like that, a little more than that, and open it up and then staple it back together, making sure that and then oversew it. But I just did the side to side functional end to end.
Yeah. I mean, if you're using a 60 millimeter stapler, 6 centimeters, something of that size. So basically you hand sewed it together, and I love that. And did you do 1 layer or 2 layers on your hand sewn anastomosis of the stomach?
I did 2 layers. So I did the back wall Lembert 2.0 silk sutures, full thickness 2.0 Vicryl, and then did the outer layer of the 2.0 silk Lembert. Yeah,
and on your inner layer, did you do that running?
Running.
And so did you run from both sides and then tie on the front?
Start in the midline and then basically 2 sides. So start in the midline, go towards myself, towards one to close it with canal stitches on the edges, and then also started midline and went away from myself as described in Chasen's Operative Anatomy.
There you go. Did you consult Chasen's prior to the case? Or you got it in your brain. Very good. Awesome. Well, I love it. That's a great story, and I can't resist talking about the technical aspects. So thank you for indulging me.
Sure.
Let's move on to the last segment of the show, resources for the busy rural surgeon. So what is one great resource that you love that you just think every rural surgeon should know about?
I think everyone should know about the Boss Business of Surgery series podcast and yours.
Love it. Yes. So I guess I didn't say that. So Dr. Vertrees has her own podcast, and she's been quite an inspiration to me in terms of listening to what you put out there. There's a lot of stuff that's similar to what we're talking about. Of course, what I'm talking about is much more focused on rural surgery specifically. You've had some rural guests, and I would say that yours is more focused on the workplace environment, and mine is more focused on specifically rural surgery and then potentially the technical aspect because I like talking about that. But it's been so helpful for me listening to your show. And you have then, I also coach a lot. I've coached a lot over the past, we'll say, I probably started coaching in 19. And I've always had some sort of a coach, sometimes more than one. And when coaching is kind of the same ambiguous term, but I've had coaches in the real estate world, masterminds that I'm involved in where we're kind of coaching ourselves, GoPod group, that's a group of people. It's just, there's no replacement for a parent that cares about you, a spouse that cares about you, that really understands the ins and outs and talking to them. But breaking away from that and actually coaching with somebody one-on-one. Also, if you pay somebody to coach you, it's almost like you value it, or at least I do, like value that time. So right now, my active coach is actually PT who grew a big PT business, and we meet twice a month, basically for about 90 minutes a time. And I'm very strongly considering actually coaching with Dr. Vertrees. Almost certainly I'm going to do that because there's a lot of synergy there. But what is your podcast about, and what is coaching? Before we wrap up and get out of here.
Sure. I'll keep it brief. So if you head to bosssurgery.com, that's where you find the podcast. And also I am a coach as well. I've been a coach since 2020. The podcast and my book and my coaching all focus on the lessons not taught in residency. So I would consider myself more of a surgeon career coach, if you think of it that way, because we all have the things that we help with. So the podcast initially started with me just myself. But what it turned into was an interview format, which has been far more interesting to me and also more informative, because whatever problem I find that I encounter, I'll find someone and we talk about it. And so Dr. Lehman's been on there as well. Of course, we talked about oral surgery, the economics of oral surgery. And so I have over 200 episodes now. My VA has actually gathered all of our topics, all the podcasts under specific topics. So now you'll be able to go to the website. It's almost finished, where you'll be able to go to the website and click on, okay, I need to deal with clinic, or I've got this difficult colleague, or I've got, I'm looking at a career shift. So it's all the lessons not taught in residency. So things that you encounter when you go out after residency. And it's been very helpful to me. One of the more recent ones I think were really important is talking about emotional capacity. We talk about skills and knowledge, but we do not talk about the ability to manage the things that come up, like dread and uncertainty and anxiety. And unless you find a way to manage that, the emotional capacity, you have to expand that with things like gratitude and appreciation and inspiration. If you don't have a balance of that too, this is actually what can decline in our career. And I think that's the biggest threat for most people. My coaching is a year-long program, program. I also do one-on-one coaching, but my group program is for surgeons. And it's a year long. And the reason it's a year long is that there are certain things that I think that we really do need to know beyond residency. And so I do 3 months of dealing with difficult colleagues. So how do people set us off? How do you deal with other people? How do you interact with these other people that are also doing hard jobs? Which is essentially, how do I manage my stress response and theirs?
Correct.
And there's 3 months of dealing with complications. So this is what happens when my hands cause injury to somebody else. How do I continue to do this hard job? How do I manage myself? How do I protect myself, both mentally, but also in my career? And then there's 3 months of power negotiating. So this is where I take my knowledge of my interactions with other people. I take my knowledge that I've learned about my strengths and weaknesses, and how do I move the needle forward in things that matter to me? So how do I advocate for myself? How do I basically lion tame the people around me, all the things that come up, and how do I manage people around me and inspire them? Because that we are really becoming the leaders and CEOs. And then the next 3 months are it's called Stop Hating Clinic, because, well, can't get you to love it. But this is about, how do you now run your practice like the CEO? We are trapped in employee mindset of I just do what I'm told, or I do things within the constraints. We don't really tap into the idea of vision and efficiency and inspiring other people and getting most other people who work with us. And that is really what I learned as a private practice surgeon. I've added another layer that's going to weave throughout this, which is really what young attendings need to know. Since I've had a lot of younger partners, I'm starting to see some of the things, new lessons that I've learned but didn't have much clarity on, which is, how do you get other people to help you? And also, how do you plan your clinic? How do you plan gaps in your career? Like when you have a disruption in your career, whether it's an illness or a new family, how do you manage how you plan your career? And how do you understand how you get paid? I just had that webinar, like I mentioned, called Math Not Drama. And find the replay of that on bosssurgery.com. And that's about, how do we make the problems that we have math problems that we can solve, rather than the drama of irritation, resentment, annoying, things like that. So what I want to do is to give people more tools on how to approach this very hard job that we have in a way that makes us better, our patients better, and the people around us better. Because in an interaction, you just need one person who feels safe and grounded. If you can be that person, you're going to transform the people around you.
Yeah, I can see that being true in scenarios in my life. Thank you for sharing that. Real quick, for just a minute or two, could you give me a high level on how to get other people to help you? When
Yes.
we're supposed to be the lone wolf, I thought.
Oh, yeah. Well, it's basically we think about ourselves and what we need. So the best way to get other people to help you is to understand they want to help you. They just don't know how. So the one thing that I learned as I'm going along is I have to make their jobs easier. If I have this idea that they want to help me, I need to make sure that I tell them all the things that I need. Like we were talking about bleeding the inguinal hernia. If I have not said, hey, I might need these things, and I now ask for things, I make their job so much harder. They're going to get frustrated. I'm going to get frustrated. So a lot of this has to do with stepping back and saying, I don't rely on a pref card. I tell people what I want directly and often until they get it. I don't expect other people to do it. I don't expect the pref sheet to do it. I don't expect them to just know. I know enough now about my case, the simple steps. So I invite them to be part of the process. And so at the beginning of the case, when I tell them about something, I was like, I think this is going to be a straightforward inguinal hernia. I'm just going to need 3 5s. I'm going to need the 530 camera. I'm going to need this mesh, have this available, have this available, have this available. It takes me 5 minutes. I don't rely on a pref card. They have it ready for me. They feel capable and strong and available. So when I need something like, oh, she said she might need that, that's how you get people to help you, is that you have to be the one who is controlling what is happening. And this is simple. Easy. What typically happens is, why don't they have that? This is their job. They're supposed to know that. There's a magical unicorn pref sheet. So it's the things.
It's the same way I do it every time. It's on my card. I've been doing it the same way for 5 years. Why are you still handing me that?
I think what you do is
that didn't work for me.
It can work if you have the same team. And also, if we stomp our feet, they'll get it. But it's not inspiring people, and it's not making them want to help you.
I've noticed something. The places where I've been having the most fun and having the most success, because I'm in multiple places now, right? I actually believe that the people around me want to help me.
Exactly.
In the places where I am having the most success. In the places where it still feels hard, I truly, like, especially the one, I don't believe that they want to help me. And I actually believe that. Like, I don't think they want to help me. But the thing is, maybe that belief is the thing that's keeping it from, being fun and everything. But I truly don't believe it. Like, I think they're against me. So then, so.
Well, one, I mean, you don't know if you're right or not, but it's certainly not helping you. So
right.
What I would offer is, like, that isn't a thought that you offer yourself that might be true. It might not be true, but it's certainly not serving you. So can we think of something different?
Right. Interesting. This is what coaching is all about to me.
Yes.
Is, saying the crazy things that are the actual thoughts that go on in your head, and you can change your thoughts. You don't have to. I'm not going to change that thought because I don't have to anymore because I'm not there. But it is actually something that you drive, is your actual thoughts. And sometimes the things that you believe, you might challenge yourself a little bit and say, what if that's not true?
Yeah, exactly.
Yeah. Well, this has just been insanely valuable for an hour and a half. so thank you for all this time.
We do have this problem, right? It's so much fun to talk to you that I think every time we sit down and talk, it's really long.
It just goes this way. I mean, I could talk for another hour and a half, but we better call it. I might have to split this into 2 episodes. We'll see, because there's just not a lot that I want to leave out. We could simplify it a little bit, but I just appreciate you taking the time, everything that you're doing. I had one more question about your group. Is everybody in your group a general surgeon or just some kind of surgeon?
Just some kind of surgeon. I've got gyn-onc, ortho, pediatric transplant, urology, general surgery, breast surgery, trauma, I may mention.
But we're all wrestling with the same basically problems running an OR and high stakes type of a case and high performers and whatnot. So that makes a lot of sense. Okay, wonderful. Well, thank you so much, Dr. Vertrees, for joining the show. Really appreciate you having. I hope you actually come back some other time. So thanks for the time today.
Anytime. Thanks, Dr. Lehman. So much fun talking to you.
I hope you enjoyed this episode with Dr. Amy Vertrees. She was fantastic, and I really enjoyed the show. I appreciate you sticking around for the second of the two-part series, and we'll see you on the next episode of The Rural American Surgeon.